morning, everyone. I think we're going to start. I hope everyone is in a comfortable seat. I see some spaces, but it would be much better if we fill the gaps. But if you're sitting comfortably, that's okay. Great. So, distinguished delegates, esteemed colleagues, honored guests, and friends, my name is Dr. Gaston Nyiridira. I'm a senior consultant anesthesiologist and senior lecturer at the University of Rwanda and chair of postgraduate medical education at African Sciences University. And I'm a board member, advisory member of TORG. So it's a great pleasure to be here, and I'm honored to be selected to co-chair this important conference. And this conference is the second annual scientific conference and 10th anniversary of the TORG, partnered with King Faisal Hospital, Rwanda. So happy 10th anniversary to TORG. Can you applaud for that? Great. So on behalf of organizers, the TORG, the Operating Theatre Global, and King Faisal Hospital, Rwanda, I extend my warm welcome to all of you. We are deeply honored to host such a diverse group of participants from across the globe. We have surgeons here, we have diversity of healthcare providers, we have nurses, we have in every angle, we have researchers, innovators, policymakers who have gathered here in Kigali, the heart of Rwanda, to share the knowledge, experience, and vision. Did you know Rwanda is a country of 1,000 hills? Who counted so far? I'm asking the guests. It's even more 1,000 actually. So you will realize it when you visit. Beautiful country, safe to stay, and nice people actually. I think I'm right. Great. So Rwanda is a nation that continues to inspire the world with the spirit of resilience, innovation, and commitment to progress. It's therefore most fitting that we convene IRCAD, Rwanda, a world-class center dedicated to advancing surgical training and healthcare. To our shared responsibility as a global community to ensure surgery is not only safe and innovative, but also sustainable, so that progress benefits every patient and everywhere. So we want to acknowledge and appreciate the Operating Global, TORG, and King Faisal Hospital, Rwanda, for organizing this milestone event, and our supporting partners for TORG, King Faisal Hospital, Rwanda, 2025. So whose collaboration has made this conference possible. We start by IRCAD. Actually, when we talk about this, we will be happy to applaud for them because they have done a good job to organize this. So as you can see on this table, on this we can see IRCAD Africa, the Robotic Global Surgical Society, TORG+, Jason's Health Organization, the G4 Alliance, Black Belt Academy of Surgical Skills, BAS, European College of Aesthetic Medicine and Surgery, ECAMS, Magister Trujaye, did I read well? And Kigali Top Events, KT, the CPD Group, Safe Surgery Initiative, Intersurgeon, Safe Surgery Innovation, Medical Students Association of Rwanda, MEDSA, Let's together clap for all those who have contributed to this event to happen. Once again, we extend our gratitude to our partners, supporting organizations and faculties for the invaluable support throughout this conference. So this conference is co-chaired by myself, as I introduce myself, and we'll be joining a co-chair with Dr. Kara Neal, with Acting Deputy Vice Chancellor for Academic Affairs and Research at Africa Science University. She's also the Chief Education, Training and Research Officer at King Faisal Hospital, Rwanda. She brings a strong background in higher education, including her doctorate from the University of Liverpool, leadership at the University of Global Health, Equity, and the service as a board member of the Project Management Institute's Education Foundation. Please, let's just give applause to Dr. Kara, who is co-chairing with me. So today marks the beginning of an exciting journey. Over the course of this first day, we will hear from inspiring keynote speakers, engage in scientific sessions on surgical safety and innovation, participate in the dynamic panel discussion, and enjoy opportunities for collaboration and networking. Together we not only learn, but also create connections that will last far beyond this conference. So I encourage each of you to engage actively, to share your insights, opinion, and to embrace the diversity of ideas and experiences in this room. It is through our collective wisdom that we can truly pioneer a better future for surgery and for healthcare. So, for that is my distinct honor to officially open this conference. Let us begin the journey of learning and collaboration together. Welcome. Vous êtes les bienvenus au Rwanda. Welcome to Rwanda. I can. Great. Delegates from Tanzania, Uganda, any East African countries, delegates from Ethiopia, okay, now I want to welcome people from Europe now, who traveled a long way to come to this conference from Europe, anywhere in Europe. Yay! Welcome, delegates from the US. Good. Delegates from Asia. Australia. So we have covered everyone, right? But I know there's some people attending from across the world online, virtual. Just welcome to the conference, and we hope you're hearing us and you're following us. So now the conference has started. Our guest of honor is Dr. Menelas Nshimana, who is going to talk about workforce development as a catalyst for global health equity, the impact of Rwanda's 4x4 strategy. So, Dr. Menelas is a distinguished physician, educator, and a global health leader dedicated to advancing healthcare delivery and equity in Rwanda and beyond. He currently serves as the head of the Health Workforce Development Department at Rwanda's Ministry of Health, where he oversees national strategies for building a sustainable and resilient health workforce. He is the immediate past vice president of the both Rwanda Medical Association and the Rwanda College of Physicians, and serves as a senior consultant physician in internal medicine, as well as an honorary senior lecturer at the University of Rwanda's College of Medicine and Health Sciences, mentoring future healthcare leaders. Dr. Yeshimana has also played a critical role in Rwanda's preparedness and response to emerging and re-emerging infectious disease. As Case Management Officer for the Rwanda Joint Task Force for Higher Consequence Infection Disease, he has contributed to national efforts against COVID-19, Ebola, and Marburg virus disease, ensuring effective clinical management and workforce readiness. With a strong academic background that includes an MBBS, M.Med internal medicine, and Master of Science in Global Health Delivery, Dr. Nyeshimana combines clinical expertise, health system leadership, and global health diplomacy to champion workforce development as a cornerstone of equitable healthcare. We welcome Dr. Menlas on stage for his talk. Thank you.
Dear Ambassador, Professor Adibusula, I pronounce very correct. Will you excuse my French accent? I'm francophone by background. Deputy Vice Chancellor Cara, Chair Gaston, international friends. I followed you last night. I think most of you landed last night. I was on Twitter, viewing the media. I'm monitoring the landings and the smiles on your face, so I knew you before I came here. And colleagues from Rwanda, it is always a privilege for me to be at this specific venue. I was told between Chair Gaston and Professor Adibusola. Which country was that? When you talked about meeting in Kigali? It was nothing.
It was Nigeria.
Nigeria. See the power of conversation, the tea breaks, the side meetings, they lead to this event. I bring you also warm greetings from the Ministry of Health of the Republic of Rwanda, Murakaza neza. If you have started taking a Rwanda language, Murakaza neza. So you join us at a pivotal moment, right in the midst of a transformative reform, as highlighted in the video that we just watched in the next few minutes. I'll walk you through the details as it captures the equity and the strategy that we are talking about. If all is well, I think I will use this gadget to move to the next.
Yes. Yeah.
Okay. So, as a country, I just want to show you who we are. We had a target. If you look at the full document of the 4x4, there are numbers of cards that you want to have. Some are large, especially the quantitative output of the nurses. We aim to have more than 6,000 by 2028. And again, this explains that nurses spend, I think, 80% of the time with the patient. So that's why they are more in numbers. Midwives, again, but other cards as well are equally important. You will see that if you combine all together, we are almost 43% of total targets of enrollment. Because the reform is just 2 years young. We still have 2 years to go. Probably catch up with the numbers. For some numbers, probably have gone beyond targets, considering that we are halfway. For example, if you look like the dental surgery, the residency training and fellowship, because the trainings are usually 2-3 years. So you can quickly upgrade. We call it an upgrade, a promotion from a general practice to a resident. It's a prestige, isn't it? And the fellowship is also a prestige, but it takes shorter because at that level you're looking at the skills in your hands, because you have had 6 years of training to consolidate the knowledge you need as baseline. And speaking of the skills and why I like this place I hope they will show you the second or the third floor, where there's a very fancy room where skills, especially for the surgical disciplines, for the nurses and the surgeons are taking place in the most trendy, minimally invasive approach. I hope it's part of the yes, the chair is not in here. But if you go to the registry, I I always go there and take a photo on Da Vinci whenever I pass by. I have like 5 of them or 10 of them. So if you go at the registry, the doctor's registry, the nurses and midwife registry, the pharmacy registry, and the licensed professional registry, these are the numbers that you find. Again, the biggest contingent or the biggest battalion is the nursing battalion because of what I just mentioned and some countries that are coming up. If you go to the last allied health professionals, we find very rare people on this continent. We call nurse anesthetist or anesthetist or non-physician anesthetist. I think these are scarce everywhere, and many, many other cadres. But of course, you cannot train all your cadres in one institution. Some schools have to grow. For example, the medical school had to increase. The most increase was seen in nursing and midwifery schools, from 4 to 11 midwifery schools, 8 to 12 nursing schools, again to produce the largest number of cadres you need in this specific category. If you look at the World Economic Forum jobs, future jobs, or jobs expected in the future, you don't even find medical doctors. That was offending, but it's fine. But you find in the high-ranking future jobs, you find the nursing professionals. So that's how they are very, very, very important. The teaching hospitals have to increase as well, specialized teaching hospitals. But of course, we are still struggling. I don't know if this is unique. We are still struggling with the numbers of intensive care beds. The care of the very sick, we have few beds. Out of the 1,200 that we need as a country, we only have 179, but we are trying to our best to catch up. And it's not just setting up a room for ICU, it's also ensuring that people in that room have been trained to the purpose. Intensive care physician, intensive nursing, biomedical engineering, all the processes. Operating theaters, very few as well. I don't know how we came up with these small numbers, but if you look at the 5 theaters per 100,000 population as a standard, then today we should be having 700 operating theaters. I don't know how we end up with 100. But again, we are fast tracking the construction because you feel it. When the surgeons, they said that the surgeon should be in the OR at least 3 days per week. If the surgeon is not in the OR 3 days per week, then something is not right. Of course, the rest of the day they can teach, they can do things, but every week they should have a full day dedicated to OR. If you look at what we were as a country yesterday, if we did not change the networking, the way we speak to people, the way we engage, the way we speak to our partners on the continent and beyond, if we continue the business as usual, it was going to take us 185 years to reach the number of the workforce that we needed. But now Gaston and everyone, they take time to network whenever they go out there. We make sure that we send people out there for conferences to network, and they also see ways we synergize our efforts in workforce production. So this is the blue trajectory. We are somewhere around 2.1, and our goal, the minimum, should be at 4.5 and beyond. Because if a country has a very minimum or weak density of health workforce, definitely there are things, there are services that they are not providing. And to translate in the health state of their citizens. They'll be sick, they'll be having surgeries that are delayed, tumors that are growing. So you need a minimum number of workforce. Then the infrastructure, the equipment modernization, they should follow. But you start with the people, because I can go to Japan tomorrow and buy 100 modular ORs, state-of-the-art, recent innovations. But you cannot buy surgeon over there. You cannot buy nurse. You need time to work with them and to build their knowledge and skills. Am I doing it right? Okay. So if you look at the African continent, it's a young continent, very young. I think 70%. They are below 35. So they are very trainable. There's no bank that will not invest in a 20-year-old. Usually banks mind when you start to invest in a 70 years old or 80 or people close to retirement, but someone young, it's an asset for the country. But if you look at the people who are eligible for medicine, for example, on these slides, we get 3,000 applications as a country, but our seating capacity in medical school, we can only seat 300. So what happens to the people who don't make it to medicine? It becomes a homework for us to create schools, because for us that's something we should be able to quickly catch up with and pick up, because it's the future it's our future depending on this. This is just the one school. Training slots or training capacity from the historic average enrollment, you see that on average we're enrolling at 50%. Historically, we as a country have close to 8,000 training slots. All the health professionals, including nursing slots, medicine, pharmacy, if you put them together, it's somewhere around 8,000. But historically, we are putting only 1,600 trainees. And this is how we kind of derate our future. Is we talk about sustainable health workforce development. But in the 4x4, as we kickstart the 4x4 in July 2023, by December, we did manage to occupy the slots at 50%. By December 2024, we are at 71%. It's the change in the global politics and stuff. Today, we are 27%, but we still have 6 months to go. We believe we also occupy probably close to 50% or below. So if you want to, we are projecting ourselves into the future. The surgeon, the breast surgeon that we need in the next 5-6 years, the oromaxillofacial surgeon, the dental therapist, the orthopedist, we need in the future. And who need them? It's us, because we are going to be sick at that time. So to prepare them, it's now. To make sure that we find them, provide them whatever they need, and we make sure that they are enrolled, and we make sure that they have all they need to excel in those different tracks that they are engaged in. You can have visiting teams. We all get visiting teams in Africa. Visiting team from Italy, visiting team from Madagascar. But do they stay from January to December? Probably not. They can visit you a week, 2 weeks, but when it comes to January to December, Monday to Sunday services, you find a way of sustaining yourself over time. You can also encourage people to network, like people who are close together, like Rwanda, Tanzania, Nigeria. It's very short distance. You can operate in Lagos today, and the next day you are in Bujumbura, and the following day, if the conversation is the cooperation is tuned to that level as well. Mobility also is very important. So we have 20 residency programs in this country that are accredited by the Higher Education Council in different disciplines: surgery, medicine, lab, emergency and perioperative, and so forth. And maybe for information as well, here medical school is 6 years, residency is 4 years all across. Fellowships usually is 2 to 3 years. So the fellowship programs, we have 19 that already are running in different disciplines, again, medical subspecialty, and pediatric, surgical subspecialty, women health specific specialties. So you need, these programs we prioritize based on the need of the population. If you have a big chunk of unoperated breast cancer, it's time for you to set up a breast surgery fellowships and start training as you treat as well. These are many that are coming up. You see again some from medicine, some of the elderly medicine, geriatrics. Our life expectancy used to be 20-30s a couple years back, but today at least we have a smile on our face, because I know I will live up to 70 at minimum. I'm not dying tomorrow. Not even the next year. I will be there up to age 70. And who knows? Hundreds also. 100 years. So it's time now to start investing in the care of a senior citizen. We used to call them old men, but that's not polite. These are senior citizens, former professors, mayors, medical students who want to have aged. So it's time to invest into their health to ensure that they can pass through those years healthy. Future program, you see sport medicine. Are they taking you to the stadium, Amahoro? We position ourselves in the region as well as the sport as a sport hub. Let's see if you have a match, so that you put on the jersey. You have Vubi and you go and cheer at the national stadium. Then when you see these big events in the sports, of course you need sports medicine specialists. If you have rare events, rare sport events, you can approximate and take me or take Gaston to treat the athletes. But once you have like every month, very big events, we have I think the global cycling event. That's going to be for like last for one. Will you be still here? Stay here. Leave afterwards. Don't be in hurry. So of course, those development now will require like very precise people in the matter, like sport physicians, like sport rehabilitation specialists, physiotherapists. It becomes something that is very, very accurate. The University of Rwanda, the largest university in Rwanda, has been there for years, probably 100 years or so. It's been there for a while. Most of us have been there, but today we have, as I said, at least 5 universities operating in Rwanda. So the public and private partnership is enhanced. We do, as you see in the video, for us, we are interested into the person. We don't care if they attended a private school or a public school, still we pay. The government, we have money, and the trainee, they bring their youth, their intelligence, their will, and you pay whatever needs to be paid because we're interested in them being the nurse of tomorrow, the dentist of tomorrow. So private partnership, private-public partnership is very enhanced in the 4x4 reform, and we align our curriculum so that we train in the same way. Nursing specialties are now into what we call a residency model. Nurses train on the job. If I'm a bedside nurse and I want to specialize, for example, in neonatology nursing, I will spend my 2 years just in neonatology.
Recording stopped.
Full time. So these are the residency model that we implemented. We have priority as well as a country to continue investing in subspecialty training, specialization of the nurses. I heard that the more advanced is the surgeon, like cardiothoracic surgeon, they start to become picky. They want a nurse who specializes in that as well. And they want a nurse who's not rotating. They want to be hand next to a nurse that is just earmarked for that services. That's why we support our nurses to earmark them to specific subspecialty. I don't know if it's different to do to be a surgical nurse in prostate surgery and to be a nurse, a perioperative nurse in cardiothoracic surgery. Is it different? Or you can easily switch them. So they hate it anyway. They like to stay organized and grow with science as well. Anesthesia and non-physical anesthetists, it's a scarcity, I think, on the continent. They are very rare to find. That's why we give Gaston escort so that he remains healthy. She's not allowed to get sick, because if you get sick, then we are in trouble. Pharmacy also, because pharmacy has taken to the next level. It's not just hospital pharmacy, but also it's industrial. Are they going to biotech? We are into biomanufacturing as a country. If there is a disease that requires a certain vaccine, instead of running left and right, India, Japan, trying to find a vaccine, why can't you just put all our brain together and manufacture what we need? That's why we now put pharmacy as a priority, but that level of pharmacy, biomanufacturing, industrial pharmacy, and more complex things. Bone marrow transplant, it's something that is very costly, usually affects people as they are. The people that have seen need bone marrow transplant are usually 18, 20, so we make sure that they receive the services, because once you do it properly, your life is prolonged significantly. And of course, undergraduate medical and dental surgery. You cannot have enough doctors as a country. So especially with the current mobility, we train as many as we need. And since now we are 2 years into the 4x4 reform implementation, we have some sensible impact, for example, by setting up the GI specialty as a training program. it tripled the access to GI-specific procedures. People had access to diagnostic like endoscopy, colonoscopy. The disease was detected much earlier, and they had a curative treatment. Same with cardiothoracic surgery as a fellowship program. When I talk about the visits or the missions, when we are into the visits, yearly visits, we are doing like 30 cases of open chest surgery as a country. But when we said maybe this is not the way to do it, we should do it as a program. And now we are around 200 surgeries per year, uninterrupted. So you walk in with a mitral stenosis threatening your life, the same day you receive surgery. Before it was wait for the Italians to come back, wait for the Americans to finalize their travel and stuff like that. But now it's uninterrupted. You get it, you get treated instantly. And the referrals, we also changed the way we said we are training OBGYN. Maternal and child health is very sensitive in Africa. Men in Africa are not as important as mothers and children. Do you agree with me? So maternal child health is very sensitive, and again, we needed a large pool of obstetricians to take care of mothers, especially when they die giving birth. It's a very bad for a country. It's a very bad indicator that shows or flag that country as a problematic country. So we did expand our training sites, teaching site that hosts OBGYN residency from 5 to over 12, I think. There are 12 or 13 becoming resident sites, so that output at once moves from 12 per year to 70 per year output. Then again, you can deploy equitably. And when you seed also a program in a certain geographic area, you change the referral pattern in that area. So if you look at what transformation or results we got by seeding these programs outside of Kigali in the other teaching hospital, the referrals, OBGYN referrals decreased significantly, and also the mortality within those hospitals reduced significantly because the staffing has moved from a general practitioner who's shuffling in all services to a fixed faculty and resident in a service from Monday to Sunday and January to December. And this is going to be followed by many other specialties as well, PEDS and many others. Digitalization is very key. Our goal is to ensure that once I am following a certain training track, quality is already in the makeup. I shouldn't be a surprise to the council. Provisional council should be able to follow what I do in my daily basis for 4 years, so that by the time I complete, I am licensable. And by being licensable instantly, I am employable. So that's the trade license employed that has to be very tight. Training, usually it's the Ministry of Education. Licensing, there are these very powerful councils, registrars, and the Ministry of Health has the employer. So we find a way to put ourselves together as probably as one-stop center, like the trade license and employ. And it requires digitization. We see less and less papers in the Ministry of Health. We used to have a sofa that was always full visitors because we are very manual. But once a digital system came in place, the sofa is empty. We kind of miss the crowd. We miss visitors to speak to us. So that's the other side of digitization. We need to close the gap. We need to continue to invest in subspecialty and specialized nursing education. Infrastructure development is constant, same with equipment, upgrade. The endoscopy, we used to have an endoscopy, I think, 10 years ago. That was monocular, like you have to look through. But today, everything's on screen, so digitized, so beautiful. So modernization of the equipment also is something that we engage in day-to-day job. Let's also show the new Kainovo microscope of the neurosurgical procedure with AI capability. So many things that we have in this area. Partnership is very key. Partnership within the country, private and public partnership within the ESC region, partnership on the continent. We have 400 medical schools on this continent. So we need to telephone each other on a daily emphasis. We need to visit each other. We need to teach together. So partnership is very key. And partnership beyond the continent, everywhere you can think of. And these are the countries that we are constantly in conversation, mutual visit, mutual support, mutual collaborative research, and so forth. And this list will continue to grow over time. Thank you very much for your attention. And once again, murakazaneza mu Rwanda. Thank you. Welcome to Rwanda. Murakazaneza mu Rwanda.
So because in Rwanda, we also support the well-being and all strategies to avoid any cities, I would like you to stand up and just have 1 minute to take care of ourselves. Adele? Oh, you don't want?
So get some free space. You can call God to come. On your sides, be sure not to hit the person next to you. And then we are going to sing one beautiful song we used to sing back when we were in kindergarten. And the best thing, because this is, I'm sure we have a lot of people who work in the health force, including me. I want to do some course in health management, maybe psychology, so that I get out of mass communication. So this is what we are going to, I will demonstrate. When I say head, you touch your head. Shoulders, knees, and toes. So let us start together. I will sing, you do the touching. My voice is very good. 1, 2, 3. Head, shoulders, knees and toes, knees and toes. You. You let us start again. Start again. We are going to do 3 rounds. Head, shoulders, knees and toes, and eyes and ears and nose and mouth. Head, shoulders, knees and toes. At least once is okay. Brother is really flying.
Just to make my patience exercise. That's very good. Thank you very much. So, I think we're progressing. Now, we're going to welcome the important person on this conference. I will say meaning it because she's been standing for this conference. Despite all the ups and downs, but she's been very, very strong and it's been on it where everybody else was somehow down. But we really appreciate her effort. So, Ambassador Professor Dr. Adebusola Adenike Ookole, did I read well? Thank you very much. So she's going to talk about a decade of impact. I told you this is the 10th anniversary of theology. Strengthening surgical systems through global collaboration and innovation, the role of the operating room global theology. So Ambassador Prof. Dr. Adebusola Adenike Ookole is internationally recognized healthcare leader, innovator, and advocate for surgical system strengthening. She's the founder and president and the CEO of the TORG, and the founding director and the CEO of the Operating Room Global Center for Education, Research and Innovation, CERI, Ireland. And she serves as a chair of the Ambassadors Club, the Robotic Global Surgical Society, TORG+, where she also leads as a salesman and a quality controller for the Intercontinental Training Program, ITP, and is a member of the TORG+ Fellowship Training Committee. She is also the founder and the CEO of Adebusola Ookole Training and Consulting, ATC, and an associate director at Jason's Health Organization, a synergy of multinational humanitarian organizations. Over her distinguished career, she has her qualifications from leading academics and medical institutions, including Ondo State University of Medical Sciences, University of Benin Teaching Hospital, Babcock University, Nigeria, Harvard University, Université Côte d'Azur, France, Royal College of Surgeons in Ireland, and Anglia Ruskin University, Cambridge. With a career spanning surgery leadership, research, education, and global diplomacy, Professor Dr. Okole is dedicated to advancing innovation, capacity building, and global collaboration in surgical care. Her pioneering work through TORG over the last decades has transformed operating room systems worldwide, leaving a lasting impact on patient safety, surgical education, and healthcare delivery. Please, all together, welcome
First of all, I would like to say thank you to everyone who made this possible. Distinguished guest, Dr. Menelas Nkeshimana, if I get that right. Yes. I really want to say thank you. Esteemed colleagues, co-chairs of the conference, our partners in Faisal Hospital, IRCAD Africa, and all our partners connected, all attendees, members, friends, well-wishers. Really want to say thank you for being here. Today I'm going to talk about the role of the operator in Global TORG. I believe I've been introduced. That was very long actually, so I wouldn't want to bore us with more introductions again. So basically, you can call me Prof. Adebusola, or Adebusola for short. It's fine, whatever you say. Thank you so much. So I'm going to talk about the operator on Global TORG. So basically, it's a multidisciplinary professional platform for operating theatre staff, all disciplines, both nationally and internationally as well. We started from Nigeria. That was 15 years ago, 2015, 10 years ago, actually, I apologize. It started in 2015. We started with strong members, actually, very committed members. Background then was I wanted personally to go outside my own country, see what's obtainable in other countries, compare cost of living, practices, international standards. When I went online, looking for platforms like that and people to actually interact with, there was zero. So there was no one to actually ask questions and say, oh, what's obtainable in your country? And I discussed that with my husband, who happens to be the co-founder of the organization. And he actually suggested, why not we start this? Since there was zero, so why not we start this? And we started the organization with just about 9 members, and today it has really grown. And I'm going to show you that journey, 10 years journey. So the audience, basically, as I said previously, it's operating theatre staff, all disciplines, nationally and internationally. Currently, we have 42 disciplines represented: surgeons, physician assistants, anesthesiologists, perioperative nurses, ANPs, PACU staff, CRNAs, CSTs, depending on the country. Some countries would have more of each category than other countries. Now, that is at the center of what we do: knowledge, collaboration, advocacy, innovation, research, multinational, multi-center research, education, and global impact. The vision is to be the premier professional platform for operating theatre staff globally. And as much as possible, we want to empower surgical professionals with the knowledge they need. The focus is on low and middle income countries so that they can get access to the collaboration, the information they need to actually improve patient practices. Sorry, I think I went too fast, sorry. Now, on our core values, so excellence is at the center of what we do, innovations, integrity, patient at the center of it all. We believe in the power of collaboration, collective expertise of our global network, and as much as possible, we empower surgical professionals to actually reach their full potentials, and we ensure transparency in all communications. So this is the journey of operating on Global TORG. By the time we clocked 1 year, exactly, we had 1 country represented in the organization. That was the founding chapter, which is Nigeria. Every country represents a chapter in the Operating Room Global TORG. As mentioned previously, we started with just 9 operating room professionals, and by the time we were 5 years, we already had 45 countries and 23 chapters with 42,000 operating room professionals as members of the community. And 10 years, this August, we now have over 107 countries. I think it's 108 as of today. 107 countries represented, 25 established chapters, and over 200,000 operating room professionals globally. And the journey has actually experienced steady growth in its membership base. As mentioned, we started off with very, very committed members, dedicated, and initially before we started having the standard governance structure, we had 9 dynamic moderators that actually ensured that the organization was brought to the highest standards as much as possible. Those are the 9 showing on your screen from New Zealand, USA, Canada, Nigeria. Those are at the time we started going online. We discovered that this gap was actually in existence in other countries as well. They also want a platform whereby they could interact with professionals in other countries. You cannot be, it's like an umbrella for operating theater staff. So surgeons and anesthesiologists, we're all one in the Operating Room Global TORG. Thanks to these founding members and leaders who actually laid the foundation of a very strong organization. Those are the countries represented in Operating Room Global TORG at the moment. In Africa, we've got 31 countries represented. In Asia, 29. In Europe, 33. In North America, 5. In South America, 5. In Australia and Oceania, 3. And in Central America, we've got, that should be 3 represented. That's 107. I think Russia is coming twice on this chart because Russia is part of Russia is based in Asia and part of it is in Europe as well. So this is the representation of member countries as mentioned, with Africa constituting about just second to the highest, 38.3%, and Europe constituting the biggest in terms of the membership base of the Operating Room Global TORG. As per our membership, we've got women actually taking significant lead in the organization in terms of membership, not in terms of engagement, let me put it that way, but in terms of membership base, 18 to 24 years category, women have 3.4%, men 2.0%. You could say the highest is in the age range 35 to 44, with women again taking up to 22.3%, and men in the organization 7.2%. And in terms of journey, in terms of engagement by countries, we have the United States taking the lead, 48.3%, 48.7%. Philippines, that's the top countries as at August 2025. So there is a way we evaluate engagements, and we've got the standards, and we've got top applications to actually do all of those calculations. Pakistan just 4.1%. I think the first African country would be Nigeria, taking 2.3%, and then South Africa, at the bottom of the chain, and all others, they have very, very low, significantly low scores. In terms of city engagement, where the members who actually engage more are Pakistan is on top of that list. Next is New York. In Pakistan, I think IRCAD says first, then Iran. Iranians mostly, because there is language issue, they speak Persian more than any other, so they translate more, but still their engagement is actually very, very high. And in terms of our community, because the community is very wide, to improve engagement and more, we actually evaluate as well the times of engagement of the community, depending on the country. Some countries could be at night time when you have a webinar session, whereas some countries would be at morning time, some would be at afternoon time. It's a challenge, but generally, the highest engagement of our members is between 3 p.m. and 6 p.m. in BST, that's Central European time. Recently, as part of our achievements for the 10th anniversary of TORG, we established an institution review board, which is up to international standards. The IRB of TORG is registered with the U.S. Office of Human Research Protections, and also have federal-wide assurance approvals. This means that TORG can internationally support multi-country, multi-institutional projects, including those that require regulatory compliance, clinical trials, invasive procedures. So TORG IRB, Institution Review Board, is actually positioned to make all of those happen. As one of our research initiatives, we've got an international audit ongoing on WHO surgical safety checklist implementation in low-resource settings. There are about 44 institutions from the operating room global TORG represented in that multinational audit. Another research initiative currently ongoing as part of the 10th anniversary is the identification of novel biomarkers. These are the very, very beginning stage, let me put it that way. And we are looking to actually partner with one organization in Rwanda to make this happen. They call them Rwanda Ubuzima, I think. So we've had meetings ongoing. We want to, as much as possible, discover biomarkers that actually lead to like postoperative delirium for older surgical patients after major non-cardiac surgery and anesthesia. And one of our research initiatives as well is on geospatial accessibility and financial protection in relation to bellwether surgeries in resource-limited settings like open reduction, internal fixations, cesarean sections, and more. And another one again, we have that in collaboration with the University College London Department of Neurosurgery, AI-assisted surgical coaching collaboration is for pituitary tumors and hospitals that engage more in neurosurgery, so that as much as possible, we want to develop artificial intelligence and train AI to be able to help in interpretation of data and advanced scans that relate to anything neurosurgery in that regard. The another ongoing one, as part of the 10th anniversary of TORG, is in collaboration with the University of Birmingham, and that's the RAM study, regional assessment of amputations in sub-Saharan Africa. And about 200 hospitals currently are registered for this RAM study, and as much as possible, before the end of the month, from the first week of September, about 50 institutions have approvals already for ethical compliance to start this study. As part of our initiatives last year, for the 9th anniversary of TORG, we started the TORG magazine, registered to publish stories, to publish newsletters, and more publications, even for upcoming writers in TORG or even partner institutions to help bring out their voice perioperatively, surgically, and more. And as part of the latest initiative of the Operating Room Global TORG is the Operating Room Global Journal, now ISSN registered. It's a quarterly publication, CC by 4.0 license. It's an open access journal, peer-reviewed, multidisciplinary, international journal that is committed to advancing evidence-based knowledge in actually all domains that relate to the perioperative and surgical environment. The Operating Room Global TORG got its accreditation almost 2 years now, an international accreditation as a continuing professional development provider, recognized by the CPD group based in the United Kingdom. This actually underscores our commitment to delivering high-quality, globally relevant educational programs. All our programs, all our trainings are CPD accredited. Now, I must also use this opportunity to say thank you to our esteemed partner, Faisal Hospital, Rwanda. Recently, we started the clinical observership program, TORG+KFHR. The first cohort was that was in March 2025 this year. I think there's one of them in the house. Can you stand up and just yeah. I think that there was really positive feedback from that program. Internationals came into the country. They stayed for 1 month at King Faisal Hospital. They were exposed to higher standards of operating theater experience. They were able to showcase their own skills from their home countries as well. And they were supported with registrations for the Rwandan practicing license. The second cohort is going to, the application for that is going to be opened around October, November against March next year. So it's a rolling every year now, TORG+KFHR, thanks to our partnership, and we are really grateful for that. And we've got partnership with TRUGS, that's the Robotic Global Surgical Society, of which I'm the chair of the Ambassadors Club and also a member of the Fellowship Training Committee of TRUGS. What we do for the international intercontinental training programs is observerships, fellowships, and visiting professorship programs for three aspects, key aspects: robotic surgery, advanced laparoscopy, advanced endoscopy. We've got, as of today, 8 participating institutions. There is one in the United States, in Texas. There is one in Mexico. There is one in France, Orleans. There is one in Japan, Osaka, Luxembourg, Colombia, Germany, Ecuador. And we are opening 2 more soon. One is upcoming in China. So it's free for all members. It's for graduated surgeons, aspiring surgeons, medical students, international medical graduates. The fellowships for graduated surgeons and visiting professorship they have to be practicing surgeon leaders and professors. They get internationally recognized certificates after the program and more. So it could be from 4 weeks to 8 weeks to 12 weeks to 6 months to 1 year, depending on if it's just observership without hands-on experience or if it's fellowship with hands-on experience. And then thanks to our partnership with IRCAD Africa, I'm actually excited to be here. They made this happen, of which we are grateful for that. We have, for the Operating Room Global members, thanks to IRCAD Africa, they've got 50% discount for all our members of all the courses, eligible courses, for all the Operating Room Global members. Occasionally, we have members coming in for the programs for the hands-on courses, could be laparoscopic surgery, sometimes it could be 4 days, 3 days. During the programs, they get to do 1 dinner for networking dinner, lunches covered, they get hands-on the pelvic trainers, on the advanced laparoscopic equipment, and on the Da Vinci as well. So there are about 4 courses upcoming, October, November, and more. If you go on our platforms, you will see that we can announce more as well. If anyone is interested after this, and during the break sessions as well, you can also go into the lab and see what's happening inside that IRCAD Africa lab, and then you can be able to know what to expect by the time you come in for the program. And you can speak with the staff as well. They'll be able to put you through as much as possible if you are interested in any of the courses. So if you are a member of TORG or you are affiliated with us by partnership, you get 50% of all the fees of the course. We are a member of the G4 Alliance and committed to actually advancing global surgical care to address healthcare disparities impacting vulnerable populations. We have a project ongoing called the Operative Encounter Registry. This is in collaboration with WHO and the G4 Alliance, and this Project ECHO as some part of governance over that. So what we want to do, there was an issue from the Lancet Commission on Global Surgery that happened in 2015. They wanted to report on current data in the operating room environments, and they had to use old records and other things like that. So we want to build a kind of registry that is present, current as much as possible. The facility will have access to that. WHO will have access to that. You can use that for quality improvement projects. So it's ongoing at the moment. From TORG, we have about 20 organizations registered for that, especially about, I think, over 14 institutions from Sierra Leone alone, and a few from Rwanda registered for the Operative Encounter Registry program. So we are piloting that, and we hope to start soon, September, October. So that's just like a map of how the project is going to go, convey partners, create the pilot protocol, coordinate with NGOs, and see how we can actually launch pilot sites and implement this Operative Encounter project. Over the last 10 years, well, we have some strengths, we have some weaknesses. The strength is in our global network. We are committed to education and training, high quality education and training. Operation Global Talk has significant faculty research, higher standards of research, evidence-based practices as much as possible. We lead advocacy efforts, either nationally or internationally, and partnership is at the center of what we do. We rely more on our partners and collaborate with international organizations as well. Well, a lot has happened in the last 10 years before we got to this stage, like limited resources, disparity in geography of the members, making it impossible sometimes to have meetings or to discuss the way forward, and the organization relies more on volunteers. When you rely more on volunteers, you have to be flexible as much as possible. You have to work by their own timing. You have to understand that these people also, they are family, they have family, they also have their work as well that they have to be committed to. Sometimes some countries, especially some low and middle income countries, they've got outdated technology infrastructure, they've got limited internet to even connect to listen or participate in any innovation. Sometimes you want to carry out the local research, it's invasive, but there is no ethical approval protocols on site. It's a challenge. Language barrier, I would say, is another challenge as well. As I mentioned previously, Iranians, they speak Persian. As for a person, if I want to interact with them, I have to go on Google Translate to actually relate with them because they speak Persian and zero English. So it's a challenge, and TORG, and sometimes as well, most of our programs, most of the Francophone countries represented in TORG, they begin to ask, oh, we need all these trainings translated into French. You know, like they need their own sessions as well. We recently opened a chapter in Russia, so there are things ongoing. We have chapters. We have a chapter in Palestine. We have in Israel, and we've got members having all these challenges as well. So it's a lot going on, and at the same time, we also operate in the competitive landscape. You know, a lot of people participating, members of the organization, they already have their own organizations that they are committed to. So you have to put that into consideration as well. Well, we have to analyze that just to know how to improve things. In terms of innovation, we have partnership with the Surgical Safety Innovation, SSI, to develop the first world training, online training, especially targeted at biomeds to improve surgical instruments, inspection, maintenance, sharpening, repair, quality control standards, and more. And that's also, we have another program called SERI, which is a comprehensive online interactive training program. It's like the first of its kind so far. Again, that is targeted at surgical technologies, CSSD professionals, and biomeds, or even perioperative nurses involved in perioperative environments. So far, well, a lot has been said. We are now over 200,000 members. At the same time, there is still a long way to go, you know. Better is never good enough. The best is always yet to come. So this is a projected goal. Estimated size in another 5 or 10 years, we should be at over 3 million members to improve the standard and partner with as many organizations as much as possible. That's just a projected goal over the next couple of years, so that we can have that at the back of our mind as we move forward. Then our members, they say a lot of positive testimonials, either on the platform, sometimes they send emails, they send messages. They really found the platforms more beneficial to them. Sometimes there is an institution, for example, in Kazakhstan. Every training that we have everywhere, they have to make sure that all their staff, they connect and get the CPD accreditation from that program. So there are some recommend, some also ask us for way forward improvements in significant areas where we think we might improve. So I really want to use this opportunity to say thank you to all our partners that made this happen. Thank you to KT Events, thank you to Meta that provided the protocols for the conference. KT Events actually supported us a lot, and I'm actually using this opportunity to also recommend them. That's Kigali top events, to recommend them. And we have the same Universal Events behind the cameras, behind some parts of the logistics. We have the transportation team. Odavi is in the house, I believe. So I'm recommending all of them. Black Belt Academy of Surgical Skills, thank you so much. G4 Alliance, thank you so much. TRUGS, that's our sister society, thank you so much. IRCAD, that's European College of Aesthetic Medicine and Surgery, thank you so much. Intersurgeon, thank you so much. Jason's Health Organizations, Maggie Kirogi, thank you so, so much. And I must say a big thank you to IRCAD Africa who made this platform possible today and for bringing us here under this roof for hosting this milestone event. And I must say this, a million thanks to King Faisal Hospital. We are family now. I was just thinking, I think at this stage, KFHR needs to give us an office, official office, so that we can stay closer. So thank you so much for listening.
We are on time. Now it's a break time, tea break. So we're going to go out. I want you to respect time. So the tea break is downstairs, and we have this opportunity to visit the lab. There will be someone there. It's not like a formal visit. Just go and have a look and come back, right? So we'll be quick. But we have only 30 minutes, unfortunately. It's not a long time. Maybe lunchtime we'll be having time to know one another, to connect, but now it's quick because we have 2 sessions to go after this, right? Thank you very much. Enjoy your tea break. So, are you ready for the next session? Seems like you are not ready yet. You're ready? Great. So, this moment in the next session, the presenter is a friend of mine. I will take this personal. So, Dr. Daniel Davido Otobo. I add myself, sorry. So, he's going to talk about strengthening health systems for better surgical outcomes and highlight the role of policy and advocacy. So, talking about him, Dr. Daniel David Otobo is an emerging global health leader, physician, and advocate for surgical equity with a strong focus on policy and health systems strengthening. He holds a MBBS in Nigeria and has pursued advanced training through multiple international certifications, including MAN in the US, TEAM in Boston, Sexual and Reproductive Health and Right in Belgium, and Global Health in Washington. He's a Global Surgery Fellow with Operation SMILE, USA, where he contributes to advancing surgical access and quality for underserved populations. Dr. Otobo is also an active member of several professional advocacy bodies, including the American Academy of Neurology, the Association of Future African Neurosurgeons, and the Global Surgery Working Group of the World Medical Association's Junior Doctors Network. Through his work, Dr. Otobo integrates clinical expertise with global health advocacy to drive systemic change in surgical care. His contributions highlight the critical role of policy, collaboration, and capacity building in improving surgical outcomes and advancing health equity worldwide. This is Dr. Daniel Otobo. Please clap to welcome on the stage.
I'm Dr. Daniel David Otobo. It's a pleasure to be in Rwanda again. I was here in March this year, and I met Dr. Gaston in Nigeria actually, exactly 1 year ago, in August in Lagos at TRG 9th International Conference. I think it's amazing that I'm able to make it here to Rwanda because it was on the queue while I'm trying to collect food that the conversation of, hey, who should bring this to Rwanda started, and I was standing behind him and Dr. Faisal was here. So it's good to listen to rumors. You can be in them soon. But another thing is, this topic, I found the pointer. This topic is quite personal, health systems. As a Nigerian, it may not really resound a lot because everybody is in factions, but before I push in, let me give a bit of a background. The month of July was amazing for Nigerians, but it was depressing for me. Reason being, I lost 2 people in July. Consultant, someone who had just passed his consultancy exam to OBGYN, who was being managed by our neurosurgery department, and classmates. The nurses, yes, the nurses were on strike, and this classmate of mine was rushed to the hospital. So you see, the nurses on strike, the health system is already dysfunctional, and a house can only be destroyed from within. So then her family members rush her to the hospital, and the doctors are just like doing their best, and so they like tell my classmates and her family, oh, go to another hospital. We are very understaffed right now, and this doesn't really look so urgent. FYI, she was having an anaphylaxis. She was reacting to a just expired deworming drug, and her windpipes were like closing, and she was having edema, and so she was wheezing and couldn't breathe well, and all she needed was someone to spend maybe 10 minutes to listen to the history and then give her a shot of epinephrine, adrenaline, cephalin. No, they were just looking at who was standing and who wasn't standing, and then they were referring, and she was referred away. By the time someone was able to give her the epinephrine, she was too weak to recover. The brain had been in hypoxia for too long, and GCS did not improve. Then she died. My colleague, his was a health system where he keeps working, and we are quite understaffed. Although they will tell you there's something in Nigeria known as Japa syndrome, where people travel out. They blame that for the lack of doctors, but we have a situation where the doctors who are on ground, only about 45% of them are employed. So you find doctors doing Uber driving, taxi driving, other businesses, going into manufacturing, and even becoming social media influencers. I'm sure you might know a few of them, just to make ends meet. So their doctors are not employed. Dr. Chukwu Arinze was operating every day for 1 week while having severe headache, and he couldn't even listen to himself. And he finished an operation on Friday, all while having severe headache. He had to sit down during the surgery. He did about 3 cesarean sections that day. And by Sunday, he was admitted in the ICU, unconscious. And the scan showed suprasellar tumor. Suprasellar is the region just beneath the pituitary gland, between the pituitary gland and the bone there, just in the sphenoid bone of the middle cavity. And the interesting thing was, we thought it was a craniopharyngioma, that is an aggressive benign tumor, but it was something worse than that. It was an inoperable tumor. By the end of that week, he was brain dead. And a week after, his family accepted for us to do the blood. So we have a missing part of the health system. and we have a health system that kills those that keep the system alive. Welcome to the reality of medical practice. If you've not studied medicine yet, don't. I'm Dr. Daniel David, and today we are going to be speaking about, hopefully, how to strengthen this health system using policy and advocacy. Okay, it has stopped working. Oh, it's now working again. Sorry. These are the outlines with which I'll be trying to convince you and not confuse you that it's possible to change things. So first, I would like to talk about global surgery. And in simple terms, this is the right surgery for the right person at the right time for the right price, and it inculcates the 6 KPIs of healthcare. But now when you are looking at surgery, and policy and advocacy is a strong part of this. You should understand that who you are at the end of the day is the product of the system you've gone through. If someone goes to any other university to study, let's say, law, for example, and then you go to Harvard or Oxford or Cambridge or University del Milano to study law, the difference would be clear by the time you want to start producing yourself. So who you are or the results you get is always a result of the system through which you've gone. And so what does the health system currently, would I say, in Africa or low-income countries give us? In low-income countries, what our systems give us is a very poor turnover. And then, in the crowd, we have a neurosurgeon, we have a lot of surgeons, and in fact, when people ask, what are you? I say, I'm just a doctor. But I know we have a lot of specialties, and we're like, there are a lot of surgeons here, there are a lot of doctors, these two are rich. Yet, less than 6% of all the surgeries done in the world are done in Africa. And if we bring together all the low middle income countries, FYI, there are more poor countries outside the world than just in Africa. So this 6% encompasses poor countries around the world. And so all the poor countries around the world, not really poor, but lower middle income downwards, perform 6% of all the surgeries done in the world. And there are a lot of surgeries going on in the world. Now, in order to change that, you need to build a health system that helps you ensure improved access to surgery. And the only way you can do this is to improve the workforce around you, improve patient safety, and hopefully by this we will decrease mortality. We would not have nurses or other key pillars of the health system going on strike, and somebody would have at least 10 minutes to listen to my very dear friend Ruth and realize all she needed was 0.5 mil of adrenaline to celebrate her birthday 1 week from today. Someone would have noticed that if every time a consultant is doing surgery for almost 2 weeks, he has to sit down or take a shot of diclofenac or hold his head tight, and someone holding ice on his head while he's doing surgery and tells him, go and do a scan, they will find the brain tumor before it becomes inoperable. We will decrease mortality, not just for the patients, but also for those providing care. When you build a stronger health system, you need to be able to enjoy the work you do. You know, it's very beautiful. You find, I like motivational speakers, you see. You find them saying things like, do what you love and you'll never work a day in your life. If you love medicine, medicine will still kill you if they stress you. I mean, Samuel Fodok and I started speaking like years before today. He and his friend reached out to me from LinkedIn and thereabout. And there are many times they reach out to me and 12 midnight, I'm like, please can I call you back? We're about going in for another case. It is 12 midnight. I went to work by 6 a.m. Oh my God. I've been there for almost 24 hours. And I love medicine. It's questionable now though. But all the same, to build a strong health system, you have to assess the current structures on ground. The typical mindset is to keep building new things and building new things. No. In Somaliland, there was this very great nurse, I've forgotten her name, but she's still alive, and I listened to this directly from her lips in 2020 under the Afro PhD. She was speaking at the conference. What did she do? She's a nurse, she has worked outside all her life, she has a lot of savings. She came back to Somaliland. She met her government, and they started an institution where they take nurses and train them in surgical skills. Nurses are now doing cardiothoracic surgery there. The African Union does not even really recognize Somaliland as a country, but they have cardiothoracic surgeons, they have neurosurgeons. I mean, Sierra Leone doesn't have a neurosurgeon, and that's a chair in the AU. So you need to work on the already existing infrastructures. When I say existing infrastructures, I don't mean go and look for the uncompleted government projects and finish them. Human beings are existing infrastructures. Tanzania is training non-physician health workers in surgical skill also. Look at their mid-term review of their surgical plan. They've made a lot of improvements. You need to also develop a plan. The globally accepted National Surgical Plan now is known as National Surgery Obstetrics Anesthesia and Anesthesia Plan. Some people add trauma to that. Now, why is this important? Why do we always sing about obstetrics, anesthesia, trauma? We'll come there. You need to invest in training and education. I mean, even Cinderella had to train how to dance after she was granted the beautiful dress. You might have the money, but if the physicians are not trained, you are going to find a nurse doing what I saw when I was working in the northeast in Nigeria, when someone, I don't know whether it's mistakenly, whether his wife broke up with him that morning, but he injected milk into a central IV line. Milk. The patient obviously went to heaven within few minutes. You have to assess the surgical equipment and the supply chain and how they come about. Supply chain is a very important thing. If not, you are doing surgeries, and by the time you've closed the first layer, you've closed skin, you've brought together peritoneum, you've closed muscle, you've brought together peritoneum, and you want to close the skin, very proud that you've done a beautiful appendectomy. The suture finishes, then what next? Are you going to speak in tongues for the skin to close? Hospitals need to have a very great supply chain that keeps what the physicians and nurses and lab technicians and the pharmacists need at their fingertips. If not, who is going to suffer? The patient. Well seated here, but we are all just one unfortunate incident, so one severe illness from being a patient. You have to focus on patient-centered care. And something Rwanda has become suddenly great in is collaboration and partnership. And then finally, monitoring and evaluation to make sure, because you see, improvement is an ever ongoing process. You need to make sure that the result desired is the result being gotten. M&E does not necessarily mean they are doing something wrong. So, how do we go about developing a surgical policy? First, you need to have what is known as stakeholders meeting. Before a stakeholders meeting, you need to choose your stakeholders. This is known as stakeholders mapping. And then, you can create a chart where on your left-hand side, you put those who are completely useless to your plan, and on your right-hand side, you put those who are useful to your plan. And then you make a list of private and public contractors who are rich in your country. In my country, I can boast of Dangote. Who can you boast of here? I know. Now, if you put Dangote on the right, you put the Nigerian government on your right, you put the Ministry of Health on your right, and you put like other key stakeholders here, then on the left, it might sound funny, but you have people, you need people on the left, people you shouldn't waste your time meeting. And then on this right, it's 0, 1, 2, 3, 4. Those who are around the 4 points are those who are very important to you. These are the people who you should do you should put in a lot of effort into recruiting into your ideas. Those who are 0 are those who are very important and rich and may have common sense, but might not be too useful to you. I mean, what concerns Davido with national health policy? But he's rich. It doesn't mean he doesn't help people. But how does investing in a national health policy help his career as a musician? That's what he's going to look at. So he's going to be on 0 or 1. Then you focus on those on 2, 3, 4, and you try and get them on your side. In Kenya, what I did was, I started with the Surgical Society of Surgery, SSK, and then my colleagues went to the Ministry of Health, and then we recruited members from Ministry of Health, SSK, AMREF, and other key stakeholding organizations. And then this was when we started the conversation a year ago to start developing the national surgical policy for Kenya. You see, it all starts with an idea. But to move your idea forward, you need investors. And these investors are the stakeholders. In Ghana, my colleague in Ghana, a very, very good friend of Professor Adebusola, her name is Irene, pushed this forward in Ghana. And today Ghana has a national surgical plan. Do you know the advantage of having a national surgical plan? This is the advantage. Now you have the audacity to ask your government for money for things about surgery. Prior to now, a lot of our funds for health were going to HIV, TB, Stop TB Partnership, reproductive health, this and that. In fact, you could find condoms for free, but you couldn't find sutures for free. It's very important to have a means through which finances can come to you. And when it's time for national budgeting, by the audacity of a national surgical policy, fundings will come to the Department of Surgery. So, globally, it's not just in Africa or LMICs. The world was not talking about surgeries. But little by little, Tracy Chapman will say the revolution starts like a whisper. The whisper of surgery started coming in from the conversations on emergency medicine, emergency response, emergency preparedness. And what is the most common emergencies that run into the hospitals are accidents. I don't know if it's the same in your country. Road traffic accidents, assault accidents, and can you use anti-malaria to cure a broken bone? And so from the conversations of emergencies, surgery is dropping into the door. And before you know it, WHO started speaking about strengthening surgery in UHC. And then, voila. Surgery has a key point in the WHO. The year 2015 can be called the birthday of surgery because in that year, every key strong thing in surgery came. There's something as essential surgeries, DCP3. The document was released in 2015. WHO 68.15. The first time WHO really spoke about surgery. The first time surgery was mentioned on the WHO document was in 2015. And then there's this document that now forms the template for national surgical policies. These guys were so amazing. Look at them. 2030. They were so amazing. This is the document that forms the template for national surgical policies. All you have to do is just copy their plan and attach your country's name and take it to your government. When your government sees that 80% of people are living below poverty line, very soon millions of people won't be able to afford surgery. Mortality among women is high, mortality among children is high, mortality. This document was very wonderful. But this document was what opened our eyes to what has been existing. It wasn't creating false information. And so that now formed the background for health policy. And it was from that document that we saw that surgery was where a lot of people died in the hospital. Okay, you've successfully had an internal fixation and external fixation. Come back in 2 weeks' time. Your leg is either too soft or too hard, but pus is coming out. You are having fever. You are sweating as though hellfire was 2 doors from you. And then by the end of the next week, the person is dead. Post-op complications in surgery. A lot of people are very happy. They are celebrating by the time the HCG test has 2 lines. They are already buying clothes and buying dresses. Then they go into the delivery room, and then it's the trolley that brings them out. Obstetrics. And then you now find a lot of traumas. In where I think is in Rwanda, the nickname for Boda is external fixators. Yes? You guys are lucky. If external fixation is your biggest problem with those machines, come to Cameroon, come to Nigeria. If you have a skull at the end of the accident, be happy. They don't even wear helmets. And then anesthesia care, which sounded very funny, but we lacked a lot of anesthesiologists. Nurses were recruited into anesthesiology, and then they started their training in anesthesiology, even in my country, a lot of them. But even then, a lot of them were still missing. Just recently, doctors started going into anesthesiology. And then all this is happening. You see these red points? I'm not trying to compete with Leonardo da Vinci. This is not artwork. Everywhere red here lacks surgery appropriately. Just look at it. Now, a strong surgical policy, however, is going to not just be there to threaten your government. It's going to create a strong standard of care. In Kenya, we got the documents that will soon be launched. National Surgical Strategic Plan and guidelines. Guidelines for who? Guidelines for the surgeons. Something that is going to guide me to remove a defective left kidney instead of the functional right one. There are some countries that have policies that ensure that if you are to do an abortion surgery, you must use a marker to mark that area prior going into the theater. Those who know operations now knows that in my organization, we have policies that when everybody is ready for the surgery, someone walks in and says, if you are not for the surgery, go out. If you are for the surgery, remain. And then she's going to read out a name on a list. If you don't hear your name there, please get out before she looks back. And then she's now going to go further to tell who is the lead surgeon. He raises up his hand. What surgery are you doing today? The lead surgeon says the surgery. What is the name of your patient? The lead surgeon mentions the name of the patient. What part are you operating? He puts his hand on it. And then she hands him a blue marker and he bends and makes some inscriptions. And then she now goes through the WHO surgical safety checklist. These are surgical policies. They reduce wrong surgeries, complications, mortalities, morbidities that are very common in our country. Imagine a medical student in Cameroon now tells his professor, Prof, you're about to start the surgery, they haven't called the WHO surgical checklist. You are finished. That day is the day you graduate. We were on world rounds in my country, I think I was telling Samuel, and one of the senior residents who was posting through neurosurgery, because at times they make you rotate so that you are not in complete lack of knowledge, asked a question that was deemed rather unintelligent. But it was a question, however, and it's a question that could lead to the death of someone. And the consultant tells her, I'm sure you did not suck milk. You did not suck your mother's breast as a child. You know, the white milk could have translated some white matter in your brain, and you have common sense today. I never saw one of our rounds again. Such should not be encouraged. You can't do such in the West. You can't do such in the US. You can't do such in the UK. Voila, they have better surgical results than us because they accept corrections. My boss, Billy McGee, is a professor of plastic surgery at USC, Kep's University School of Medicine. And when we were even on rounds one day, he looked at me and said, Daniel, what do you think about this? I'm like, me? Right? You are asking me, sir? And he said, yes, what do you think? How do you think we can approach this? And I'm like, wow, okay. Because I didn't see it coming. A consultant asks you for advice in Africa. The surgical policy also goes further to guide the way resources are allocated. You cannot be doing a dental surgery and every time you are requesting for sutures. What are you suturing? But if you're a dental surgery that does max and fast and palate repair, that's understandable. You cannot be an ophthalmologist and be requesting for plate and screw. There are important ways that resources have to be allocated. My mentor, the head of neurosurgery in my hospital, is also the second head of our hospital. He's always doing allocation drafts and everything. And he has meetings every week with the heads of departments. The policy allocates what is going to go to tertiary level hospitals, secondary level hospitals, and primary level hospitals. And in Kenya, we'll say this level 1, 2, 3, primary, level 4 hospitals, secondary, level 5 and 6 are tertiary hospitals. I think this might be similar to Rwanda, although Rwanda might have a level 1 referral, level 2 referral hospitals. You cannot give the same equipment you are giving to a referral hospital to a primary level hospital. The policies guide this. A strong policy is just a game changer. This was when we launched the Ghanaian surgical plan. And now, further meetings in surgery Further meetings in surgery in Ghana now make references to their national surgical plans. And this was in March this year. I think this was a lecture given by, I've forgotten his name. This is a crime. Professor. Eh? He's a plastic surgeon. Faisal. Professor Faisal and his team invested a lot of time into the Rwandan National Surgical Plan. This was when they were presenting it in March here in Rwanda. I was sitting at the back. This is us starting the conversations that will lead to Mozambique now having a national surgical plan. By us, I mean Operation Smile. Not my money though. It's sad that I took this picture, but my face is not showing, but this is my laptop, so it shows I was there. This was when we started the conversation in Kenya. Latin American countries. And you know the great thing with global surgery, it doesn't care about your specialty. Who is a neurosurgery enthusiast here? You will recognize Professor Kipak. And this is also, you know, when you're talking about health system, this is the Pan-American Health Organization. So you also support other health organizations. Okay, you're doing global surgery, so you have no business with sepsis. Wait till the enteric sepsis gets to typhoid perforation. You come back to surgery. So you try to also support them so that they don't come to your table. So that you have only one case in a day instead of 2 cases and you go home to meet your children. Operation Smile has also launched a global surgery advocacy certificate course to help build policy advocates. I think the WhatsApp message went round and LinkedIn message went round. Next time you see it, please apply. I think the key place is also like Rwanda. And also in Rwanda, we have the Global Surgery Advocacy Fellowship. This fellowship takes you around while you gain skills in global surgery policy and advocacy development. Now, where does policy actually meet health system? According to Lancet, is in ensuring that more than 80% of people can access surgeries at the right time. There is no point you bringing the person to the hospital when the person has already lost 50% of their blood. I mean, by 20%, you're already unconscious. There is no point wasting time. You want to do 5,000 per 100,000 surgical volume. What does this mean? 5,000 surgeons to 100,000 population. You want to reduce the risk of impoverishing expenditure. The conversation on healthcare financing is a whole different conversation, and I actually spoke about it the last time I was in Rwanda. That's not to be spoken about here. But payment for healthcare is a problem. A lot of people become broke. A lot of GoFundMe come on Twitter when it's time for renal transplant or tumor removal or this or that. And while people are doing that, it's not as if the money goes into the pocket of the surgeon. If not, I would have changed my cap by now. Those who were here last few months know it's the same cap I wore. You need to improve the surgical workforce. And I'm not just talking about surgeons. Okay, the surgeon has finished the surgery. Who is going to be in the park? Who is going to be in the post-op? Who is going to run the labs? Who is going to bring the needed drugs? Down to the people in procurement departments. Now, perioperative mortality will be reduced with a good surgical policy. Because the guidelines that are going to guide surgery are going to ensure that you do not forget surgical equipment in the patient's abdomen. You start your surgery with 1 gram of ceftriaxone, and then you reduce common complications. And then you reduce risk of catastrophic expenditure by 20%. Impoverishing and catastrophic are 2 different things. I think Google defined it. You can check it. My recommendation, however, is to strengthen health system for better surgical outcomes. Now, this is going to require a collective effort. So let's work together. You need to prioritize surgery at a national level, not at grassroots level. If not, you are going to look like a, what do you call it, salt and pepper appearance. And you need to imagine a world where every individual,
Daniel, this was, I wish we could have enough time to explore more on that. It's really amazing. I have seen how Jackson was really highly concentrated on this forecast. And I thought everyone was the same, right? C'était la même chose? Okay, so we continue. Actually, if we are on time, after this we have like few minutes for some questions or clarifications. But for now, we are running out of time. So we have another speaker, Yves Kuyangana, who is going to talk about optimizing perioperative anesthesia management for patients with non-communicable diseases in Rwanda. So Yves Kuyangana is a student in the Department of Anesthesia at the University of Rwanda, College of Medicine and Health Sciences. He is a member of the International Anesthesia Research Society and is actively involved in research on anesthesia and critical care. His academic and professional development is further complemented by certifications from the Rwanda Forensic Institute and Health People Rwanda. As an emerging researcher, he is committed to advancing perioperative care and contributing to the growth of Rwanda's health care sector. Please, Yves Kuyangana.
I'm going to start by asking all these trainees which are presented here, especially in the OR, anesthesia, nurses, and surgery. I have a question for you. It is understood that it is a simple but somehow harder. The question is this: what would you do if you see a patient in the OR currently presenting with heart disease, elevated blood pressure, and diabetes all at once? Knowing that this is the reality for almost of the African, especially in the countries of low and middle income countries in sub-Saharan Africa, where 37% of all deaths are caused by NCDs. And this is the current number, where in 2000 it was 24 and is growing higher, which means that in the coming days, like in the 2030s, this will be the common lead of deaths, mortality and morbidity in Africa. Especially 50% of admitted patients in some hospitals, especially in sub-Saharan Africa, seems to have those NCDs, especially hypertension and other heart-related issues. Right now, I'm going to present about how to optimize preoperative anesthesia management in patients with non-communicable diseases, NCDs. My name was said Kuyangana Yves. Let us deep dive into the presentation. On the background, you know that the global data indicate that NCDs is the major burden, especially in anesthesia and surgery, like causing higher mortality and morbidity due to poor disease control. This is the lack of optimization and proper protocol to be followed during service giving in the OR. The introduction is big, but I'm going to summarize it. In low and middle income countries, this is where those issues are likely to be seen. NCDs are in between 30 and 70 years old men and women, where some hospitals lack of facilities and some important approaches like multidisciplinary management for achieving the better outcomes. The general objective of this study was to explore how NCDs affect preoperative anesthesia management and to recommend new strategies so that we can mitigate those risks caused by NCDs for the patient undergoing surgery. The specific to review preoperative risk in patient with NCDs, identify new techniques like in anesthesia as my discipline, and highlight multidisciplinary care or approaches. Also, optimizing the patient by adopting new enhanced strategies. Those are the research questions. This one, the first one, in any NCD patient, does preoperative anesthesia management compared to standard anesthesia care improve preoperative care outcome, like reducing complications, morbidity, and short hospital stays? We did a literature review where we used the PubMed and Google Scholar databases focusing on those literatures which is written from 2015 to 2024. We included the keywords NCDs, complications, and anesthesia. And we also focused on clinical trials, case studies, and systematic reviews. As we have said, the literature was used. We searched databases, we screened, including criteria was based on thematic analysis. The inclusion criteria was all the patients with NCDs who were undergoing surgery, and those were published in English language. Apart from data collection analysis, as we have said, it was published in Google Scholar. The result of the study, the results are there were increased preoperative risks, especially in those low and middle income countries where there is poor resources and the lack of proper protocols which can be followed so that we can enhance the safety of the patient under surgery. Also, advancement of techniques, where there are some countries which have improved techniques like adopting regional anesthesia rather than general anesthesia, and choose the targeted drug delivery which is appropriate than the others. Some countries are likely to form multidisciplinary care, and there are some hospitals here in Rwanda, like our first level two teaching hospitals, where they optimize the patient, but not at all. Those are the results. The global NCD deaths by income group, you see that in lower middle income countries, there is increased risks, and also by comparing to the standard care and enhanced recovery after surgery, if those who follow the standard care, the complications are reduced rather than following errors. When the optimization is flawed, the complication goes down because when multidisciplinary care engage, complications are reduced. Optimization also reduce the number of complications for those who are undergoing surgery. And when there is no optimization or establishing standard care, the complications are higher, which leads to high rate of mortality and morbidity. The findings underscore the importance of tailored anesthesia management for the patient with NCDs, where they included advancing techniques like adopting new strategies. Also, regional anesthesia and other advanced monitoring tools such as monitoring glucose and hemodynamic monitoring, also in the other approaches, have shown that those can reduce complications at all. But the challenge remains the same, where in the limited access, in lower and in middle income countries, there is limited access to advanced techniques due to lacking of some technology. The limitations were heterogeneity of studies and some resource constraints, where many advanced techniques and technologies are not universally accessible, especially in those poor countries. The implications and recommendations. First is to enhance preoperative optimization, promote the use of the regional anesthesia and the target drug delivery system so as to minimize the complications. Also collaboration, engaging different disciplines, reduce those complications that are likely to be raised during surgery. Also, education and training is crucial. Research and innovation is the vital, and global equity in care is also needed. Patients with NCDs who are undergoing anesthesia for surgery, they deserve much better, like safe, for equitable and evidence-based medications. By adopting proper protocols like optimizing, engaging new techniques, also will transform the perioperative safety for those patients. Let's commit and make anesthesia equity as on the global reality. Optimize, collaborate, and innovate. Thanks.
For nothing. Wherever there is surgery, there is anesthesia. Wherever there is anesthesia, there is surgery. Is there any anesthesia without surgery or procedure? Yes. So that's why it's really important to know, like, the number is increasing, and we need to understand together with surgeons how to optimize these kind of patients, right? Good. That's very good. So now time. So the speakers, you'll be seeing me showing you some timing, because we just remember to look at me. The next speaker is Dr. Aima Akilimali. Just correct me, because I have to make sure this is how we spell your name. So he's going to talk about surgical characteristics of appendectomy in the eastern region of the Democratic Republic of Congo, a cross-sectional study. And Dr. Aima Akilimali is a physician and researcher affiliated with the Medical Research Cycle, MEDREC, in Goma, DR Congo. His research interest focuses on surgical systems and public health, with particular emphasis on strengthening clinical evidence from low-resource settings. He has a colleague and collaborated with colleagues including Dr. Daniel David Otobo, Dr. Jonas Onesime, and excellent Rugendabanga in advancing surgical research in the region. Please, so Dr. Aymar is not here, and Dr. Daniel is going to speak. So, again, Daniel.
Yeah.
Okay, good.
So that is Dr. Aymar. Okay, so on our research paper, surgical characteristics of appendectomy in the rural region of DRC. This study was led by Dr. Aymar. So, as a form of introduction, we all know what appendectomy is. It's a surgery that is done to surgically manage appendicitis, also appendic abscess, and appendic peritonitis. The operation commonly was made popular following McBurney's description, and the operation usually performed very well, depending on the skill of the surgeon. After appendectomy, post-op, a lot of complications can occur, and this means that the surgery does not just end after the theater. Our research was aimed to describe surgical characteristics of appendectomies in the rural region of DRC. We conducted a retrospective cross-sectional study on the epidemiological and clinical characteristics of appendectomy. We did this using convenient sampling, the patient's record that was available to us, This was done on patients admitted during the study period. We recruited patients that were within the age of 15 to 45 years of age, and those who were admitted for acute appendicitis, appendicular peritonitis, and appendicular abscesses. In the clinic, we also investigated the American Society of Anesthesiology score, the Alzheimer's classification, as well as surgical complications of appendectomy. Our results, we registered about 591 patients who were admitted for acute abdominal emergencies. Of these, 196 appendectomies were performed. This gave an incidence rate of just above 34%. In comparison to other surgeries that were done, appendectomy accounted for the highest frequency of operations that were done at about 33.2%, with 196 cases recorded, as said earlier. Heniorrhaphies, however, were next in suit, with myomectomies, hysterectomies, and other surgical operations done constituting about 38.6%. Now, if you add all this, appendectomy, heniorrhaphies, and other surgeries, that's 100%. So appendectomy was quite significant. The mean age of patients that we operated for appendectomies was the mean age of patients who we did appendectomies for was 33, with standard deviation of about 13.4. Among the cases that were done, 26% belonged to the age group between 15 and 20 years of age. This was the highest age prevalence seen, while 65.8% of the participants were females. The clinical findings were surgical indications for appendectomy were mainly acute appendicitis with just under 70%, appendicular abscess with almost 25%, and appendicular peritonitis with less than 10%. For the ASA classification, more than half of those recruited had an ASA of 1, meaning that appendicitis or appendicular abscess or appendicular peritonitis was the only indication for their admission and surgery, while 21%, which is about 2 in every 10 patients, had an ASA score of 2, indicating they had another moderate issue, with about a little above 10% had an ASA of 3, indicating severe significant associated dysfunction. And about 8.7% had an ASA of 4, and 3% had an ASA of 5, indicating severe comorbidity, sometimes being completely non-functional. According to the Alzheimer's classification, almost 70% of the patients were deemed to have surgery that were classified as clean, followed by about 20% classified as clean contaminated, and 11.2% classified as contaminated, while only 1% was classified as dirty surgery. Postoperative complication, however, recorded 28.6 cases of SSI, surgical site infection, 19.8% of inflammation of the surgical sites, 18.8% complained of pains following surgery, and 12.4% of purulent peritonitis, and just above 10% complained of postoperative bleeding, with less than 10% having paralytic ileus. The findings of these studies are very important because they help us direct health managers to focus more on preventing appendicitis, appendicular abscesses, and appendicular peritonitis among the identified age group, which is 15 to 20 years of age, or will I say young adults. Secondly, the high prevalence of complications, especially surgical site infections, should draw the attention of healthcare managers and clinicians to preventing this. This study can serve as a good model for health managers and for drafting policies that are going to guide the operations of surgeons and also help facilitate in diagnosis, effective treatment, and handling of postoperative complications. Our limitation in this study were incomplete information in some of the patient's record, with things like lab results missing from them. Another shortcoming was we were not able to see the long term, so we only had these patients for about less than 1 week or above 1 week before they were discharged. And since the patients belong to a single medical center, we need other medical centers or regions to do such research so that we can compare. In conclusion, appendectomy is one of the most common surgeries in an emergency surgical treatment, and it's the surgery indicated for acute appendicitis. In our study, we found that the open normal laparotomy surgery is still effective, especially since this technique has been honed and improved over time, and in our setting, this is what is commonly done. You can please scan this code for our reference. Thank you so much.
You see the situation happening, so we want to stretch again. Adele? So, just for like 2 minutes before the last speaker of the morning, can you start, please? I'm not the one entertaining you, but I think Adele's coming. Stretch in your place, and then Adele's coming.
The other way. Up, down, hands forward, squared, and move your hand and shake your waist.
Thank you. Okay. So, the last speaker on the list this morning is Samuel. Is it Gislain? Great. Samuel Gislain Jr. for DOP. So, he's going to talk about an obstructive uropathy revealing a hydrometrocorpus in a 5-month-old child, which is a case report. And Samuel is a medical student at the Catholic University of Cameroon, School of Health and Medical Sciences. He is a conference fellow with the Operating Room Global, Georgie, and an aspiring clinician, researcher with a strong interest in pediatric surgery and rare clinical presentations. Please welcome Samuel Gislain.
It's very difficult to take the floor after Daniel, such an excellent speaker. But I'll try to impress you all. I hope that works. So this morning I'm presenting a very rare clinical scenario. A 5-month-old child presenting with an obstructive uropathy, and on further investigation we discovered that the child had a hydrometrocorpus. So I have no conflict of interest to disclose. So I would like to ask you all, especially the medical students, if you have a child with abdominal distension, what are the 5 top differential you think about? Think about it and let's discuss at the end. So as a means of background, imperforate hymen is the most common congenital malformation of the female genital tract, and it could either manifest in infancy or at puberty. In infancy, it usually occurs as a hydrocorpus or a hydrometrocorpus. So hydrocorpus is basically accumulation of fluid in the vagina, and hydrometrocorpus is accumulation of fluid in the vagina and the uterus. And at puberty, it presents as hematocorpus. So hydrocorpus is a very rare differential for acute pelvic or abdominal distension in a female child and adolescent, which is why this topic is of interest in this conference. It usually occurs in the premenarche period, that's prior to menarche or puberty, with a prevalence of 1 to 30,000 cases in this age group. Many reports have been published on this topic, but there are no guidelines. So when a clinician is faced with such a scenario, it's very difficult to know what to do and what not to do. So what did we have? We had a 5-month-old female infant who presented with abdominal distension, which was very sudden and rapidly evolving over 4 days. And it was associated with obstipation, that's no passage of gas nor stool. There was no passage of urine. The child was feeling discomfort and refusal to feed. Initially, there was no vomiting, nor any fever. 2 days after the initial symptoms presented, the child started vomiting, and the vomit source was non-villous and non-abundant. The child was lethargic, prompting consultation at the hospital. So on physical examination, we had a very weak child, ill-looking, with a distended abdomen, and those are the anthropometric measurements. I want to focus on the weight, because following surgery, the weight changed a lot. And the mid-upper arm circumference and the height helped us exclude malnutrition, because with the distended abdomen, we might think of a kwashiorkor, but that wasn't the case here. So that's what the child looked like, very distended abdomen. And it's surprising to hear that this evolved over 2 days only. So that was very unusual and very uncommon. So an abdominal ultrasound, which was the most affordable investigation the family could afford, revealed 2 fluid-filled cavities and was very inconclusive. So nothing could be concluded based on those results. We requested for a CT scan, and it revealed this. We had an enlarged uterus and urinary bladder, bilateral compression of the ureters, stage 3 hydroureteronephrosis. So this child was already at risk of renal compromise. And there was a high suspicion for a hydrometrocorpus, but there was little suspicion of a malignancy, because that was on the list of differentials. Laboratory investigations were normal, no remarkable abnormalities, except for leukopenia, mild anemia, and mild thrombocytosis, which did not really contribute to the final diagnosis. So the general surgeon who received the patient decided to go in for an exploratory laparotomy, because he didn't know what to do and the child was unwell. So he decided to go in for an exploratory laparotomy. An incision was made, and there you can see the uterus and the urinary bladder. Here's the uterus, fallopian tubes, and here's the urinary bladder, very distended. An incision was made on the wall of the uterus, and you can see mucus spilling out of the uterus, about 600 mils or so. Same thing was done with the urinary bladder. So at this point, there was a call for multidisciplinary team. The obstetrician was called, and he came and he asked that we have a look at the hymen. And at that point, he discovered that the hymen was imperforate. And he suggested that we do a hymenectomy and a marsupialization to drain the remaining fluid from the uterus. And for the anesthetic technique, it was under general anesthesia and endotracheal intubation. So following the surgery to ensure that there is not recurrence, a urinary catheter was placed both in the uterus and the urinary bladder to ensure drainage of the remaining fluids. Histopathology, a sample of the uterus was collected to rule out the malignancy completely. Unfortunately enough, there was no sign of malignancy, but there was, however, chronic cervicitis, eventually from the chronic accumulation of mucus within the uterus. The one post-op, the weight went from 10.2 to 8.3. So that tells you how much fluid was accumulated within the uterus and the urinary bladder. On day 2, the child was able to feed, and she passed out a significant amount of stool. Day 2, there was about 150 mils of urine and 50 mils of fluid from the urinary bladder, from the uterus, 6 weeks following the surgery, the child was very fine, and she had no complications. There you can see her. The initially distended abdomen was now very normal, and she was doing well. So what's the take-home message from this case? The evaluation of complex and unusual cases should be done by a multidisciplinary team. If this child was evaluated by a team of urologists, surgeons, and gynecologists, we believe the outcome would have been better. And the management should be backed up by prior evidence. There might not be guidelines, but there are other case reports that can guide towards how to best manage the case. And it's important to conduct more studies on this pathology so as to be able to establish guidelines to inform policy and clinical treatment. So this case underscores the importance of including hydrometrocorpus in the differential diagnosis of abdominal distension in female children. I'm sure when I asked earlier for 5 differential of abdominal distension, nobody thought of hydrometrocorpus. It's important to think about it, especially in the female children. And the early involvement of multidisciplinary team can lead to accurate diagnosis and timely intervention, preventing long-term complications. I would like to acknowledge the patient's family, my masters and teachers who permitted me to present this case here, and for ethical approval, we ensure that the family provided verbal and written consent. These are our references. Murakoze, Chiang.
So you have to ask, or you have written down, or some clarifications, or any additional thing. So the floor is yours. When you want to ask a question, please turn on the microphone and make sure you have it on, and then ask a question. Can we do that quickly, please?
Dr. Daniel, thank you for the presentation. My question is, what strategies can be put in place to create public awareness that surgery is an essential component of healthcare and not a luxury?
Strategy that can help to create awareness, yeah. So we can do this at the community level by health students during health campaigns and outreaches. First sensitizing the community, then they can work with their local leaders, who are the people that the regional leaders usually listen to. You can use key take-home messages like more people, or 80% of people who need surgeries can't afford it. Or better still, instead of quoting Lancet, you could conduct a quick survey in your community, and you can say things like, are you aware that in this community, nobody here earns enough to afford a kidney transplant, for example? You can use factual take-home messages that more people die from lack of surgery in a year than those who die from HIV in 10 years. You can play on their emotions, factually speaking, and evidence-basedly, and then it flies to the policymakers, and yeah. But people just really need to know, because when it comes down to it, human beings don't want to die. So start from there.
Yes, in terms of global surgery, and Prihangana talked about anesthesia and inclusiveness into the peri-operative team. My question is, who is responsible? In what manner? What cases? Everyone can be speaking out and be heard to include everyone into the peri-operative team. Thank you.
Especially in Rwanda, we have talked about a multidisciplinary approach. Especially the patient can come in the theater as emergence, but we do have types of emergence. We have urgent, emergence. We know the classifications. But in that case, we prioritize the patient with the most concern. First of all, we will check on the concern, and next, if there is any other thing that can harm the concern, any other specialty, especially those with heart tissues, internal medicine specialist or cardiologist can intervene. If there is any other issues related to the nursing team, either they could collaborate as a team. That's what can I say.
Begins. So in terms of inclusiveness, I would want to use Kenya as an example. Each surgical specialty has a chair, and the chairs have a chair. And each surgical specialty has a guideline which is about to be made national. Based on your guideline, and it's a document, so you can see the clinical responsibilities of other specialties as well as yours. So if I'm going to do surgery such as a hydrometrocorpus, for example, I know as the obstetrics as the gynecologist, I'm meant to involve the pediatrician, the anesthesiologist, and the gen surg. So having a national surgical guideline help define the boundaries through which involvements can be explored. Thank you.
Talking about inclusiveness in surgical care, I think it's best to start from the training. Like when we're still in school, what is done in my country already is medical students and nurses are trained in the same hospitals. So we can start by emphasizing on the need of collaborating together, having joint objectives, for example. In that way, we oblige both teams to work together and learn to work as a team. So I think we should start from the training. We shouldn't wait for us to become professionals before we start imposing inclusiveness on us. Maybe we can start as students, and I think that would be much better.
As responding to that question, I used to tell people everything starts from the school. So most of the time we used to compete in the schools. This is a neurosurgeon, this is what, and we make it as we are two countries fighting instead of bringing everything together so that we can be productive and work together to bring a very good solution to the matter. So it should start from the school and people blow up knowing that it is better to come together to solve any problem that is arising. I think we should think of it in that way. Thank you very much. Lillian?
None. Apologies.
Okay.
I'd like just to contribute. I'm a perioperative nurse, and I think in surgery we need to define roles clearly. There is the role of the manager, which is different to the role. It depends on the situation. So you find that sometimes people assume that because I'm a manager, then I have to be everywhere and take up anything. But in our case, when you're in a team, if the anesthetist is overwhelmed, another person takes up the role to lead the team, to allow the anesthetist do the work effectively. So we interchange our roles in a team. But the issue of management, that one is clear and is left to the manager of that place to handle the administrative duties, which are different from patient care. And I think that way, there will be more coexistence and there will also be a lot of teamwork and time management. Thank you.
Thank you very much. I appreciate it. Where are you following from? She's muted. From Zambia? Great. Good.
I'm from Zambia.
Okay, thank you very much. Concentrate and focusing on the topics, right? So maybe you can continue discussions outside and we really appreciate. So now it's lunch time. And after lunch, there will be Dr. Kara co-chairing the rest of the day. And we will start with traditional dance. That would be outside here or just inside? Inside? Great, great. So come early. So that would be in, we make it 45 minutes. We make sure we do lunch quickly and then we come back here. We need to cover the whole day without missing any topic. Okay? Thank you so much. That was it for me. The morning was good for me to see you and co-chairing this important morning. The speakers, participants, everyone, just kudos and just applause for everyone. Thank you.